Good morning. My name is Julie Valenzuela, and first I want to thank the leaders of this community for inviting me to speak. It's very much an honor. I'm a trauma surgeon coming from New York, and I was asked by the committee to think of 3 things I want ER physicians to know from a trauma surgeon perspective, and this actually was not an easy task. Please keep in mind, these are just my own opinions based on my own experiences. But there are 3 things I wanted to discuss with all of you, and I want you to know. And these 3 things I tell my trainees, my staff, the people I work with, and these are the same 3 things I tell to myself and remind myself. And so these are the 3 things that I'm going to share with you carefully. And remember, take it with a grain of salt. First, 1, I need you to be airway experts. That is number 1. Secondly, when it comes to trauma care, you need to be focused and seeing the big picture. I'm telling you, you are the ones who need to prioritize what needs to get done. And more importantly, all you need is a physical exam. Don't worry about labs and any imaging, actually. Focus on your primary assessment. When it is time to assess your patient, you set the tone, you are driving the bus. You need to be systematic and be prepared with every maneuver that you're about to do. And lastly, resuscitation is key. Even maybe more important than any procedures that I can do operatively. Resuscitation comes first. Oops. So, in the US, for most of our trauma centers, a trauma surgeon appears, as well as an ER physician. From my perspective, what I need most out of my ER physician is for you to be the airway expert. This is a skill set that you have much more experience than I do. I assume you know the steps. I'm not here to explain to you how to intubate. I assume you know how to assess airway difficulty. You do it much more often than I do. I assume you know the adjuncts, and I expect that you are familiar with it much more than I am. My personal experiences, and these are actually pretty recent experiences that have given me utter chest pain in the trauma bay. I think from a surgical perspective, we are much more aggressive to secure the airway. And my own grievances is not being aggressive enough. Maximize your chances of success. So recently, I had an elderly patient, traumatic injury to the head and mid-face, a lot of oropharyngeal bleeding, had difficulty controlling his secretions. ER physician and I both agreed we should go ahead and intubate to protect the airway, make the assessment proceed. There was discussions about the medications, and she did not want to use a paralytic, which I thought was crazy. There was no attempts to pre-oxygenate, even with the nasal cannula. That's coming out of your own literature for that. And other situations I've had is not understanding the pathophysiology of the patient, where I've had a patient with multiple gunshot wounds to the abdomen. Patient's airway is technically intact, kind of talking, but he is approaching stage 4 shock. I need to get control of the situation, which includes intubation. Other difficulties that I experience at the trauma bay. When ER physicians are unable to verbalize the airway plan and are unfamiliar with the adjuncts that is available to you, and not being able to verbalize for backup and help. So, sorry, However, I have had some great experiences with ER physicians, and the ER physicians that I know are airway experts exhibit these qualities. Number 1, they readily verbalize their concerns about the airway. They tell me, I am concerned about this patient's airway. I am telling you right now, this will be a potentially difficult airway. There's a lot of vomitus. The tongue is very large. There's a lot of blood in the oropharynx. I have significant concerns. I need you to be prepared for a potential surgical airway. And in case, if we have anesthesia available or another attending available, I would like that available as well. They stay calm and still able to tell me and the rest of the team what their expectation is. Successful airway experts verbalize and go through a checklist plan. This seems silly, but it actually isn't if you do not do it often. And remember, trauma is a team sport. You may intubate all the time. Perhaps your nursing staff, your students, your residents don't do it very often. They may forget the steps. If you have an airway checklist that you go through and remain systematic, it keeps your team on track. This is where you do not forget steps such as pre-oxygenation. And then they verbalize what their airway plan is. They will say to me, I will start with video laryngoscopy. My first attempt will be with an 8.0 ET tube. If that fails, I plan on downsizing to a 7.5. If that fails, I will be asking for a bougie. If that fails, I will be asking for an LMA. I would like that available. And worst case scenario, I will let you know if you need to prepare for a surgical airway. That is an airway plan that is verbalized to the team, to me, and lets everyone know what things we should be reaching for to help you. And part of that checklist and part of that airway plan is following the rapid sequence intubation, always using the medications. You are doing everything possible to maximize the success rate of intubation on a first attempt. And lastly, when it is time to actually execute and get control of the airway, we're human. We tend to do things over and over again, even when it is not working. Airway experts do not waste time. Ear physicians who are good do not try a second attempt at a failed maneuver. They stick to their airway plan, backup plan. As they verbalize, if I do not get this in the first attempt with the direct laryngoscopy, I will be asking for a bougie. Whatever your skill sets are, that's the plan you should be following. So here are my recommendations. I am currently at a level 2 where our ER physicians do not intubate on a regular basis, so their skill sets can be limited, and that's okay. My recommendation is take a difficult airway course. You don't have a difficult airway course? Create one. Create one for your own faculty, for your residents, for your students. This can include cadaver training or rotating with anesthesia. I'm a surgeon. I'm a trauma surgeon. How many in my junior career, how many major vascular injuries do you think I see? Especially, we'll say, subclavian artery injuries. In my last 7 years, I've seen 2 and read about, 1 that was presented during morning report. It's not enough for us to read about the cases that we don't see often or the difficult situations. I take cadaver courses. I watch videos. I do everything I can to be prepared for that situation. And I think one difference as from a surgical perspective in our training is we're forced to verbalize through procedures. In the operating room, there are some situations where I'm the only one who can see and explain what the situation is, and my colleagues cannot help me unless I am able to verbalize to them what I'm seeing, doing, and my assessment of the situation. And similarly for you, being at the head of the airway, I'm at the foot of the bed. I can't see what's going on with the airway. And even if you have a colleague next to you, It's an airway. It's one head, and your head is in front of it. So realistically, you're the only one who can really see. You need to verbalize to the rest of the team what you're seeing, what difficulty you're having. Otherwise, we do not know how to help you. So I encourage you, during all procedures, when you train your residents, have them verbalize the steps, have them verbalize what they're doing and how difficult it is or what difficulties there are. The more you verbalize, the calmer you stay during these difficult situations. My point number 2. Don't miss the forest for the trees. What I mean by that is I need you to maintain overall perspective. There is a reason why advanced cardiac life support and advanced trauma life support recommend having a team leader that you can see that stays at the foot of the bed. As a team leader, you need to stay focused. You need to see all the potential problems, but you need to keep the overall picture in mind. You need to keep the tasks focused, and you need to prioritize these tasks for your team members. Do not let them just do whatever it is they want to do. You need to tell them what you want next. Remember, trauma assessment, ATLS, always starts off with assessment of the ABCs. This should take less than a minute, realistically. Airway, I'm assessing as soon as I walk in the door. I can tell right away if I'm going to potentially have an airway problem. Breath sounds you listen to as soon as they lay on your bed. And then as soon as that's done, I'm asking for a pulse check, even before I'm getting my solid blood pressure. My first pulse check gives me so much information. It lets me already know and understand the potential physiologic derangements I need to be worried about. If my first blood pressure is low, my next move, as you all know from ATLS, I want to secure my IVs. I want to start my resuscitation. And my mind is racing on trying to figure out which cavities do I need to be triaging. This is when I pull up my ultrasound, and I will fast right away while I'm giving crystalloids. Granted, the hypotension and blood loss may be from 3 mangled extremities I can visibly see from long bone fractures, but you still need to triage the cavities you cannot see, which includes the chest and the abdomen and pelvis. So it comes to distracting injuries. And this is going to happen. You're going to see major injuries that your resident, your nursing staff, whoever's in the room is going to notice, and it starts derailing your priorities. Remember, non-critical injuries can wait. And dressings, how many times do people show up with dressings from EMS that's wrapped around, and everyone's focused on trying to take them down rather than assessment of the ABCs? Some examples. How many times do patients show up with open ankle fractures, where they may have both ankle open fractures presenting? It's disturbing looking, it's the most obvious thing, and yet it starts derailing the team. Everyone's focused on the legs, and no one's bothering, again, to focus on the airway, breathing, and circulation. This is not what's going to kill my patient right now. What I want to know is, what's my blood pressure? How physiologically deranged? How much time do I have? This happens to me more times than not. Stab wounds, gunshot wounds, and bowel evisceration. Everyone has to point it out to me. You know what? I see it. I don't care. This is the last of my concerns. This is not what's going to kill my patient. Potential vascular injury, significant hypotension will kill my patient. Hemorrhagic shock, bowel being exposed, I could care less right now. Here's a patient. This is from combat care. Airway's not intact, has some injuries, unclear what they are underneath the bandages. I say, leave the bandages alone. Yes, You need to get to it eventually. But be systematic in your approach and keep your team focused. You have an unsecure airway. You still don't know if this patient is hypotensive or not, or if they're in shock. That comes first. Patients come in with multiple splints that have been placed from the outside. Same thing. Don't take it down until you are ready. A stabilized splint is not what's going to kill your patient. Stay focused. Tell your team, I want the ABCs secured first, then exposure. I usually deal with these last once I'm ready with my own equipment and my own splints ready to go. Same thing, people come with tourniquets. There's a tendency to want to take these down and see. Stop. If it's not actively bleeding, leave it alone. Get your ABCs in order. Get them fully exposed. When your patient is somewhat stabilized, then you can take those tourniquets down one by one. Make sure you have dressings available, preferably a surgeon nearby, or a laceration tray, a surgical tray, so you can see if you can manage it at the bedside. Similarly with lacerations, if you need to hold direct pressure, this just requires direct pressure if it's actively bleeding. Put a tourniquet on, find ways to temporize, but get back to your ABCs. Recently I had a trauma where I had a patient in a motorcycle accident, crashed, came in GCS 15, airways intact, a bit tachypnic, and the ED doc tells me he's got some diminished breath sound on the left side and starts getting very, very worried. I said, listen, my O2 saturation is 100%. Let me find out what his heart rate and blood pressure is. I've got a little bit of time. Remember, your job is to figure out, yes, keep in mind all the problems that's in front of you, but do not get derailed by one finding alone. Mechanism of injury, physiology, your vitals and blood pressure, and exam findings is all you need. I do not need labs. All of my decisions to go to the operating room emergently, I don't need any lab for that. The only lab I care about is a type and screen, so if I have massive transfusion activated, I can eventually get what the patient needs. Lastly, my third point, I hear a lot of ER docs say, when it comes to trauma care, all I need to know is how to operate. It sounds great, but I'm telling you what I need for you to be are resuscitation experts. Trauma surgery, I would say, is less so about the operation. Doesn't matter what I do in the operating room. If I cannot resuscitate them to get to the operating room, if I'm not able to resuscitate them through the operating room, or manage them post-operatively. So we actually have an ER physician as part of my group practice. He did a critical care fellowship. He doesn't operate, but the reason why he's with our group, because he's very, very good at resuscitation. He knows how to diagnose shock, and he manages it very well. He gives us a fighting chance. He knows to call us early, but saying, hey, I have a patient in stage 4 hemorrhagic shock, activating MTP. I am doing all the things I need to do to get this patient ready for you. Otherwise, it doesn't matter what procedures you're doing if you're not able to resuscitate adequately. So what does that mean from your perspective, from our perspective, when we're taking care of these patients? We talk about damage control surgery. It's really damage control resuscitation, which can include surgery, but again, your first phase of patient care is that resuscitation phase. Early blood transfusion in a balanced fashion to restore their blood volume. This is also addressing their coagulopathy. You want to avoid massive crystalloid resuscitation, avoid hypothermia, and try to avoid worsening acidosis. So those are the 3 main points I have. And again, it's not really just for ER physicians. These are really for myself as well and for all trauma patients. Thank you for your time.